the congressman's on a tight schedule, so we'll get started here right on time. Good morning. Welcome all to the Bipartisan Policy Center, and for those who are viewing us, as this morning we're going to launch here at the Bipartisan Center our new Rural Health Task Force. I'm Bill Hoagland. I have the pleasure of working with our health team here on this project, led by Marilyn Serapini, you'll hear from later, who's our Director of Health, and Dr. Anand Parekh, our Chief Medical Advisor. We are particularly happy that one of our BPC co-founders, former Majority Leader Tom Daschle, along with Senator Olympia Snowe, have agreed to co-chair this task force over the next several months. You'll be hearing from Senator Daschle here shortly and other members of the task force that are joining us this morning. I also want to particularly thank the Helmsley Foundation and Walter Pinther over here for their past and ongoing support to BPC on rural health care issues. This work would not be possible without their generous support, and I thank you very much, Walter. For now, however, in the interest of time, it is my honor to quickly introduce Congressman Jody Arrington from the great state of Texas in his second term representing the 19th District. I got to know the congressman in his first term when he was appointed to by Speaker Ryan to be the only freshman member of the Joint Select Committee on Budget Appropriation Reform. The committee did produce a bipartisan, bicameral consensus package of reforms, and Congressman Arrington played a very significant role in achieving that consensus. But unfortunately, under the rules that were set up for the consideration of that legislation, it did not gain a supermajority vote to pass, though I know the work continues on and the congressman continues to be involved in this. Congressman Arrington earlier in his career was an advisor to then Governor George W. Bush, Texas governor, and then later, of course, advisor to President Bush. He was Chief of Staff and Chancellor of the Texas Tech University system before being elected to Congress in 2017. Importantly, he is a graduate of Texas Tech University, and his Red Raiders just made it to the Final Four of this year's NCAA Baseball World Tournament Series. Congratulations, Congressman. He also was president of Scott Laboratories, responsible for healthcare innovations, including telemedicine, which is a critical issue as we relates to our rural issues. Currently, he serves on the very powerful Ways and Means Committee, where he prioritizes rural issues. And finally, as a real sidebar, for those of us who are old enough to remember the day the music died, the 19th District of Texas includes Buddy Holly's hometown of Lubbock, Texas. So, Congressman, I'll turn it over to you.
Thank you, Bill. How about them Red Raiders? I know when I do my guns up, I'm taking a chance of being arrested in the District of Columbia, but hey, we're very proud of not only being in the national championship game, Division I basketball, but Senator, going to the World Series. Not bad for a university in the largest cotton patch in the world in Lubbock, Texas. I am so honored to be here and to work with you to solve a very pressing problem that rural America, and I would say every American, faces, because Senator Daschle knows all too well, as do most of you in this room, that as rural America goes, so will go the country, because we are the food, fuel, and fiber capital centers, production centers of this nation. That means if you like a safe and affordable and abundant supply of food, and we take that for granted because the price, Senator, doesn't fluctuate like the price at the pump, and so many of our fellow Americans think that food shows up at the grocery store. Henry Bonilla knows differently because he's a Texan, and he knows that we are the largest ag-producing state in the country, and it is critical to this nation's, not just our economy, not just to country living. This isn't about subsidizing a lifestyle. This is about making sure we have food security and energy independence. This is, and for me, okay, personally, as a kid from small town America, grew up in Plainview, Texas, it's not just the breadbasket, it's not just that rural America is the energy basin, it's that it's the backbone of this country. And when I say backbone, I mean cultural backbone, the values of faith and family and freedom and hard work, and common sense and common decency. I love what, and I can't remember who said it, about the highway to humility is not cluttered with a lot of traffic here in Washington. What we need to do is cut a country road to some common sense in our nation's capital, amen, and solve some problems. And I think this is one of them, Bill, that we can actually roll up our sleeves in a bipartisan way and go to work at providing real access, sustainable access to health care for folks. As I said, our farmers, our ranchers, our energy producers. If you do not have critical infrastructure, and we've made rural health care the centerpiece of that. When we worked on a farm bill, for example, farm bills are critical for our family farmers and ranchers, our ag producers. They have critical funding for infrastructure. We focused on broadband and expanding access to high-speed internet, closing the digital divide, like in the 60s, 50s, when they were trying to electrify the rural communities. And this digital divide is critical because the underpinnings of telemedicine and telehealth, which I think is one component for solving the access issue to healthcare in small towns and rural communities, that has to be in place. And we used to provide healthcare from Lubbock, Texas, which is the thriving metropolis in the 29 counties that I represent. We used to pipe specialty care to places like Childress, and through their hospital provided specialty care to their community where they would have to travel otherwise over 100 miles. So it doesn't work for everything, but that's one example where we made some headway even in the Farm Bill, for heaven's sakes. We introduced an amendment, Senator Daschle, to allow community hospitals in rural areas to refinance at lower capital costs, lower interest rates. It was a small thing. I think it's a Band-Aid. I want to work on bigger, bolder structural changes so we can really save these communities and these community hospitals and give these next generation ag producers hope that they can carry on the family tradition, hope that they can continue to put clothes on our backs and food on our tables and keep the lights on if they're independent oil and gas producers or wind energy producers. And I think we've made some headway. We extended the low volume adjustment, Medicare dependent, for more than just 1 year, so there's better certainty and help to these community hospitals to plan. But again, they're dealing with, real simply, in the best country way I can say it, they don't have the people. They don't have the numbers. It's not a business proposition, Bill. They do not have the numbers, and it becomes a public good imperative for our nation to make sure that that these guys have this sustainable model. We're kicking around some things that I don't think will cost much, like removing some of the requirements that just don't make sense in these small community hospitals. Half of these guys in 44% of them operated at a loss. A third of them were vulnerable to close. We've lost 100 since 2010. and many of those in Texas. We just had one in my district. I have the most rural hospitals in any district in Texas, and we've probably got more rural areas than any place. And so it is a real crisis. But to get that next generation farmer and rancher and energy producer to stay and take the tremendous risk that they already have to take by nature of the business they're in, but then to say you won't have for your family, for your children, access to basic care, it's untenable. It is untenable. And I'm talking to these guys all the time, and they're dropping like flies. And it's going to affect everybody, urban, suburban, and rural alike. I don't think I have a whole lot more to say other than let's get to work. And I'm looking out at Senator Daschle and Henry Bonilla, a dear friend, and man, we've got the brightest minds and the most experienced policymakers. And you know what I love about this issue? When we're so dysfunctional so much of the time, and this is both sides, by the way. It's the culture, it's the broken culture up here. There are still issues we can work together and put our partisanship and political differences aside and put America first. And I think this is one of them, Senator. I really do. I'm so honored to even be in the same room with the likes of you and Dan Glickman, the Secretary of Agriculture. And I'm just telling you, this country boy from the hometown of Jimmy Dean, Plainview, Texas, is who saw the real sausage being made. Okay, now this gives a whole new meaning to making sausage up here. But listen, let's make a difference. Let's make a difference. And Bill, thank you again for the great honor of working with everybody in this room. I know y'all are committed. I know you're passionate, and I know you stand with me as a champion for rural America. And all they do, the people, the values, and their way of life, and all they contribute to a great United States of America. God bless, and go West Texas.
Thank you, Congressman. And I just want to say that I grew up, in fact, we still have a family farm in Indiana. I get back, I know the issues back there, personal issues that we had as getting health care, even in the area that I was, which was rural, but nearly not as much as West Texas, I can assure you. Anyway, now I have the very high honor to introduce the Chief of Staff of Health and Human Services, Office of Secretary, Peter Urbanowicz. Peter reports directly to Secretary Azar, having been appointed to that position in January 2018 following Secretary Azar's confirmation. As the department's chief of staff, Mr. Urbanowicz is responsible for coordination of all the efforts of the HHS operating agencies and staff divisions. He previously served as the deputy counsel at HHS from 2001 to 2003 for the then Secretary of Health and Human Services, Tommy Thompson, who happens to be a senior fellow here at BPC, and that was, of course, during the George W. Bush administration. At that time, he was working with then General Counsel Azar at HHS. So this is a return duty to work with Secretary Azar. He was part of the team that, in fact, drafted the Medicare Prescription Drug Improvement Modernization Act. I know that Majority Leader Daschle was there at the time in 2003, and that led to the creation of Part D in drug benefit in Medicare. Earlier in his career, Mr. Urbanowicz served as Executive Vice President and General Counsel of Tenet Healthcare Corporation. We are pleased that the Chief of Staff could join us briefly this morning, particularly since we know that the Secretary and HHS has placed priority on rural health going forward. Our task force, Mr. Urbanowicz, looks forward to working with the Secretary and you as we address the challenges facing the delivery of health care to those in rural counties throughout the United States. So, Peter.
Thanks, Bill, for having me here to this group. It's a tough act following Congressman Arrington, his fellow Texan. He really set out the issues that I wanted to talk about today in terms of rural health. What you have been working on here and what you're doing is essential. It's tackling a major issue in American healthcare, and that's access and affordability of healthcare in rural communities. As the Congressman noted, for too long, challenges in healthcare in rural America have been met with either short-term solutions or worse, they've just been simply ignored. So this administration, the Trump administration, and Secretary Azar is very dedicated to providing long-term, sustainable health solutions for rural communities, for the patient, the provider, and the taxpayer. As the Congressman noted, for all of us who live in the cities, our rural neighbors sustain our way of life. They grow our food, they milk our cows, they cut our timber, they fuel our homes, cars, and industry with oil and natural gas. And if you've driven through large parts of Texas, which I have, and Kansas, and Oklahoma, and Wyoming, they're wind turbines. They send electricity to our iPhones and all those sort of gadgets. But these communities can't survive without access to essential services. That includes schools, stores, water, telephone, broadband access, and especially access to health care. When a community, when a town loses its school, its grocery store, its post office, and especially its hospital, it feels like it's not a town anymore. Rural health and access to rural health is a vital mission to the Department of Health and Human Services. Our mission as a department is to improve the health and well-being of every American, and that includes a special focus on the 57 million Americans who live in rural areas. We as a department at HHS support rural health in many areas and many ways, from our community health centers to our federally qualified health centers, our Office of Rural Health, and with several payment features through the Medicare program. A year ago, Secretary Azar asked me to convene a rural health task force within the department to coordinate all of our activities in this area. We have a large department with all kinds of agencies and programs, and sometimes you get siloed and you don't really work cohesively together to tackle big issues like this, like rural health care access. So we have gotten together a task force that includes all the agencies that have equities in this area. And our goal is to have an understanding not only of the challenges, but what kind of policy changes can we make administratively, and then working with Congress legislatively to make some changes in these areas. We're working, as I said, for long-term solutions. We want to make a long-term solution, and we also want rural healthcare organizations to migrate into a value-based system, which is what we're encouraging the entire healthcare system to move towards. Closure of critical access hospitals, a dearth of primary care services, financing challenges are all issues that rural hospitals and healthcare providers are faced with, and we want to tackle them. I appreciate the leadership of the BPC in taking on this issue. I know that you've been researching this issue and developing solutions for some time and suggestions. I think this polling data, which I understand is going to be presented later today, is going to provide some very good information on a kind of a roadmap and the issues that should be tackled. As we think through these challenges, we've outlined three principles. Secretary has outlined three principles that we want to think about in terms of addressing rural healthcare issues. And that is sustainability, innovation, and flexibility. So on sustainability, the first issue is we have to address the precarious financial situation of so many rural hospitals. As I said, in rural areas, the hospital is the heart of the community. If the hospital closes, the community can face significant economic disruption. And we know that these closures are happening rapidly. The congressman already noted some that happened in his district. We hear from congressmen and senators all the time about hospitals that are either closing or close to closing or financially impaired in their district. So we want to take some steps to address them. One of the ways that we're doing that right now is CMS is looking at the wage index. It's a payment feature, a payment add-on in the Medicare program that in some some ways has disproportionately adversely affected rural communities and rural hospitals. So we are looking at that with our payment update this year and hope that we'll have a proposal in there that will benefit rural providers. But in order to have a more sustainable model, we've got to move beyond the way the hospital might be designed today and figure out how it should be positioned. Maybe a 25-bed hospital that has an average daily census of 3 patients a day doesn't make sense, but some kind of facility in that local community does make sense. So one of the things that we're looking at through our a department within CMS, which is our Center for Medicare and Medicaid Innovation, is to develop some models or a proposal or challenge rural communities to come up with a model of care and payment that works. So we are working on right now and hope to announce sometime later this summer or early this fall a new model for rural hospitals that will provide a pathway for stakeholder coalitions of providers, purchasers, payers to invest collaboratively in figuring out how to model care in a rural community. It'll move from a one-size-fits-all, from just having the acute care hospital, to one that focuses on preventive care, or especially chronic care, which we see so much in rural communities where you have an aging population. The second principle, innovation. We have a lot of opportunity here. Many rural communities are expanding and improving their access through use of telehealth, not only to provide services that otherwise would be impractical, but to leverage expertise from academic medical centers. We at HHS, we've expanded the array of services that can be provided through virtual channels in Medicare and in Medicare Advantage and other parts of HHS through our Health Resources and Services Administration and through the National Cancer Institute. All of them are working together to try to figure out ways to disseminate knowledge and disseminate care through use of telehealth or virtual health that would expand access in those communities and cares. The last principle is flexibility. Even as we expand the kind of virtual care that CMS will pay for, some states still, there are licensing restrictions on the kinds of care that can be provided virtually. Licensing rules that prevent healthcare professionals and like nurses and physician assistants from practicing at the top of their license or imposing undue or burdensome supervision restrictions can hit rural areas very hard. If we let professionals practice to the top of their licenses, we can impact patients in rural areas who suffer from chronic illnesses, diabetes, COPD, heart disease. These are patients who require routine monitoring and intervention. And if we can have these professionals out in the community acting to the top of their licenses, I think we can make a great deal of difference in those patients' lives and give them access to health care in their community. All three of these principles that I mentioned, sustainability, innovation, flexibility, they all recognize that we need to think about how we pay and provide care in rural communities that's probably very different than the way that we're doing it right now. The scale of the problems we're dealing with require that kind of rethinking, and that's why it's great that we've got a group like the BPC that wants to come up with some new ideas, new models, work with us, and ultimately as we come up with some ideas and we can prove that they work, maybe embed them and make them more sustainable through legislative changes as well. So, Bill, I just want to thank you. I want to thank your group for being at the forefront of this issue. Thanks for this polling information. It'll be very helpful to all of us, and thanks for everything that you're doing on this very important issue.
Peter, thank you so much for your remarks and being here today representing Health and Human Services. Thanks also to Laura Truman as well. Great that the department has shown tremendous leadership in this area, including federal agencies from CMS and HRSA and many others. Hello, everyone. I'm Anand Parikh. I'm the Chief Medical Advisor here at the Bipartisan Policy Center, and I want to extend my thanks to all of you for joining us as we launch our new Rural Health Task Force today. A key theme of today, I think, as many of you have already heard, is that rural health is not a niche issue. Rather, it's a top-tier health policy issue impacting every state in this country. At BPC, we've been very focused on rural health issues, particularly over the last 2 years. In 2017, we released a report from our Appalachia Initiative, co-chaired by Senators Mark Warner, Tom Tillis, David Perdue, and Joe Manchin, which focused on boosting Appalachia's prosperity and economic growth and addressed rural health issues, such as chronic diseases and associated risk factors such as obesity, opioid addiction and overdoses, and the shortage of healthcare professionals in the rural workforce. In 2018, BPC released a report with Tivity Health on the implications of social isolation for rural aging. The report strove to ensure a common understanding of the impact of social isolation on the aging population, particularly in rural America, as well as outline high priority and actionable solutions that could have an immediate impact on reversing social isolation, especially in rural communities. Most recently, with the support of the Leona M. and Harry B. Helmsley Charitable Trust, BPC released a report entitled Reinventing Rural Healthcare, a case study of 7 upper Midwest states, which outlines ongoing healthcare challenges in rural America and discusses real-world implications of existing federal policies, as well as opportunities for improving both healthcare access as well as delivery. At this time, we'd like to show you a short video summarizing BPC's previous report.
Rural America is, well, nearly all of America, but it represents a far smaller share of Americans. It's 97% of our landmass, but only 1/5 of our citizenry live there, some 60 million people. At the Bipartisan Policy Center, we're creating a roadmap for providers and policymakers with roots that lead toward a reinvented rural healthcare system, one that will better serve all rural Americans. We're focusing first on 2 large swaths of the rural U.S., Appalachia, which includes all of West Virginia and parts of 12 other states, and on these 7 states of the upper Midwest. Rural Americans face greater disparities and higher barriers to quality health care than those in urban and suburban America. They are typically older, poorer, and sicker. They are more likely uninsured or underinsured, and they often lack easy access to primary care. They also face a greater threat of dying from diabetes, heart disease, cancer, and stroke. And they risk higher rates of obesity, tobacco and opioid use, mental health issues, and social isolation. In 2016, rural suicide rates were 40% higher than urban rates, and the numbers driving the national opioid overdose epidemic have reached crisis proportions. Similar stresses are being placed on the rural healthcare system itself, especially the estimated 1,300 critical access hospitals.
All across the state, rural hospitals are on the brink of collapse.
These institutions and other rural healthcare facilities are facing major challenges to staying open. As a whole, they have fewer patients and bring in less revenue, are hit harder by rising healthcare costs and government regulatory requirements, have less negotiating power for buying equipment and supplies, face shortages of qualified healthcare workers, and struggle with the distances from critical and specialized care services. So, what are some prescriptions for a comprehensive approach to reinventing the rural healthcare system? Rural RX1. Better match services to community needs. Not every community needs a critical access hospital, and no one-size-fits-all policy will do. Some communities will be better served by facilities that mix primary care and emergency services. Rural RX2. Create innovative new funding mechanisms. Pay for rural healthcare providers should be based on a model of value versus volume of services, a model scaled for low patient counts and to the financial realities of rural healthcare delivery. Rural RX3. Train the next generation of care providers by building and supporting a workforce of rural primary care physicians. University residency programs should expose providers to rural environments and train nurse practitioners and physician assistants to fill primary roles in rural communities. Rule RX4, expand telemedicine services. This technology is promising a new way to connect patients in underserved areas with healthcare providers and to offer them specialty treatments. It also creates peer networks to improve recruitment and retention of rural care providers. Telemedicine networks require investment in broadband coverage and reimbursement for those services. Creating the routes that will lead to a transformation of rural healthcare in America is possible. Getting there will require sustained commitment by healthcare providers and policymakers in each rural community and in all 50 states, and a comprehensive approach that puts patients first.
Thank you. So the goal of BPC's new Rural Health Task Force will be to review the learnings from BPC's prior report, which we believe are all interconnected and can apply beyond the 7 Upper Midwest case study states to all of rural America, as well as take additional ideas from many thought leaders and experts from across the country. We want to hear from you. We want to know your ideas, and now make specific and timely public policy recommendations to improve rural health care and health outcomes. We're thrilled to have a terrific task force which will lead us in this effort, and it's now my honor to introduce one of the task force co-chairs, Senator Tom Daschle, who will introduce the task force, discuss its work, as well as provide the results of a new poll commissioned to identify rural health challenges. As most of you know, Senator Daschle is a BPC co-founder and a former Senate Majority Leader who represented the state of South Dakota in the United States Senate between 1987 and 2005. He is also the founder and chairman of the Daschle Group, a public policy advisory of Baker Donelson, where he provides strategic advice on key national issues from healthcare, energy, transportation, and the environment. Thank you, Senator, for being here today.
Good morning, and thank you, Anand, for your kind words. My colleagues in the Bipartisan Policy Center's Rural Health Task Force and I thank all of you for joining us today. You've heard about some of the challenges rural America is facing, including the 106 rural hospital closures since 2010. In response to these mounting challenges, the administration, the Congress, and other stakeholders have proposed a variety of competing ideas. Yet there is no center of gravity to organize an effective policy initiative. So the launch of the BPC's Rural Health Task Force comes at a crucial time with the 2020 presidential and congressional campaigns now underway. We hope to bring these critical issues to the forefront of the candidates' agendas. More specifically, over the next 12 months, this task force will convene rural health and policy experts on the national and the state level to inform our work. We'll visit areas hit hard by hospital closures and workforce shortages and host public events and forums in rural states struggling with the same issues BPC identified in its initial report. Together, we're going to develop and promote a rigorous and politically viable rural health agenda, ultimately producing recommendations for policymakers that will be released in 2020. I'm especially grateful to serve as co-chair with Senator Olympia Snowe. She has been not only a dear friend of mine, but a highly respected leader on health issues for many years. I can actually think of no one more qualified to co-chair this task force now. We're joined today by a number of distinguished colleagues on the task force: former Congressman Henry Bonilla of Texas, former Congressman Tom Talkey of Iowa, Dr. Jennifer McKay, the Medical Information Officer at Avera Health, and David Blair, the Executive Chairman of Accountable Health, who will be joining a panel discussion at today's event. I'd also like to acknowledge our additional task force members who were unable to be here today, and they include former Governor of Mississippi, Ronnie Musgrove, former Senator from North Dakota, Kent Conrad, former Maryland Secretary of Health and Mental Hygiene, and now Executive Director of the American Public Health Association, George Benjamin, the Director of Rural Policy Research Institute Center for Rural Health Policy Analysis, Keith Muller, former Administrator of the Healthcare Financing Administration in the George H.W. Bush administration, Gail Walensky, former White House Healthcare Advisor in the Clinton and Obama administrations, Chris Jennings, and former Pennsylvania Secretary of Health, Karen Murphy. As one of the first objectives of the Rural Health Task Force, in partnership with the American Health Association and Morning Consult, we polled rural voters to hear directly from them about the challenges communities are facing today. What they shared highlighted the urgent need for change. Rural voters cited challenges in access to medical specialists such as cardiologists, oncologists, gynecologists, and mental health professionals, primary care physicians, and hospitals in their local communities. 54%, more than half of rural voters said access to medical specialists is a problem in their community compared to only 33% of voters in non-rural areas. Similarly, 47% said access to quality health care is a problem compared to a mere 34% in non-rural areas. These issues of accessing health care services include long wait times and excessive distances to care. When looking at the rate of rural hospital closures in America, these data points should come as no surprise. We took a closer look at 3 states, North Carolina, Iowa, and Texas, to better understand how access to health care differs across rural populations and in states with varying politics. We chose these states because they have significant rural populations and are certainly important states in the 2020 election. In North Carolina, 1 in 3 rural adults say access to medical specialists and access to quality health care are problems in their communities. 71% of rural adults in North Carolina say the cost of medical care is actually a barrier to accessing medical services and treatment. This trend continues in Iowa, where 46% of rural adults say it's difficult to access urgent care, medical specialists, and behavioral health professionals. Also, half of rural Iowans say easy access to medical specialists is a problem in their communities compared to 33% of the national non-rural population. And in Texas, where there have been 17 hospital closures since the beginning of 2010, 1 in 5 say it is difficult to access hospitals, urgent care, primary care physicians, and medical specialists in their communities. Half of the rural respondents in Texas said distance to receive care was a barrier to accessing health care, and half said insurance coverage was actually as big a barrier as anything else they have to address. When it comes to accessing medical services or treatment, rural voters were more likely than non-rural voters to agree that appointment availability and distance to care were significant barriers. All voters agreed that the cost of health care, the cost of prescription drugs, and insurance coverage were all major obstacles. The polling results are telling of the challenges rural health care is facing today, but these trends can be reversed. In fact, the desire to address this issue spans party lines, even at a time when Democrats and Republicans seem to be able to agree on little else. We were heartened to see in our poll that 92% of Democratic voters and 93% of Republican voters agree that easier access to health care in rural communities is an important public issue. 3 in 5 voters would be more likely to vote for a candidate in 2020 if he or she addressed access to health care in rural America. These numbers illustrate why this project is so important and why the BPC is poised to lead this discussion. Clearly, voters are unified on the issue of rural health and are looking for thoughtful solutions. BPC's Rural Health Task Force intends to accomplish 3 primary objectives. First, define a clear path to shore up and strengthen the current rural health care system. Second, to address barriers and improve opportunities for rural participation in new delivery models. And third, to build on successful proposals to bring and to keep a quality healthcare workforce to rural communities. This poll reinforces what we already know. Rural Americans do not have access to the quality, affordable healthcare they need, and the time to act is now. I will now turn the dais over to Director of this health project, Marilyn Serafini, who is leading the effort, and Dr. Parekh, who is going to introduce our panel.
I'd actually like to invite our panelists up to the stage. Well, thanks to all of you for being here today. We're really excited about starting our work on this task force, and in particular, you just heard the results of our poll from Senator Daschle, and we're going to talk both about the results and also about the challenges in rural America. So we're really excited to have with us today up here members of our task force, and also Walter Panzier, who is with the Helmsley Charitable Trust and is supporting our efforts. So to my immediate left is David Blair. He's chairman of Accountable Health Solutions, which focuses on building and acquiring technology-enabled solutions to improve quality, increase efficiency, and reduce costs in the delivery of health care. Next, we have Congressman Henry Bonilla, former congressman from Texas. Dr. Jennifer McKay, she's an internist and medical information officer at Avera Health in South Dakota. I already alluded to Walter Panzier, who's trustee for the Leona M. and Harry B. Helmsley Charitable Trust. And then at the far end, we have former Congressman Tom Talkey, former U.S. representative from Iowa. So normally I wouldn't start with the political question, but given what we heard on our poll, which we conducted with the American Heart Association, and Morning Consult conducted this poll for our two groups, we heard something very interesting. We heard that voters really care about rural health, and that 3 in 5 of them plan to or believe that they will make this part of their voting decisions in 2020. So before we dig into the details of the rural population and the challenges and opportunities, I'd like to ask our two former congressmen if they would talk about this, talk about the political landscape and the prospects for getting something done. You know, these results are compelling, and the response was bipartisan. Again, it included 73% of Democrats and 53% of Republicans say this is a big issue for them. We also know that Senator Chuck Grassley, who is chairman of the Senate Finance Committee, says he wants to do something on rural health care. This is a priority for him as well. And as you heard from Peter from HHS, this is quickly becoming a priority also for this administration. So, Congressman Bonilla and Congressman Talkey, can this truly be a bipartisan issue? Are the stars aligning? Is the timing right for policy change in rural health care? Can we get something done? And how do you see this occurring? Why don't we start with Congressman Bonilla?
Well, we are living in a time of great political divisiveness, as everyone knows, but I think Senator Daschle and Congressman Arrington clearly said this morning that this is an issue that Republicans and Democrats can hold hands, actually, and celebrate success down the road, especially when you have information that was presented this morning that shows overwhelmingly that the public supports this and that it could actually enhance their political prospects. When members and senators now do events back in their states, they're oftentimes met with hostility and angry crowds, but if they were to start holding events like this, I don't see how anyone could do anything but say, yes, this is something that we'd like to see done. And unlike Obamacare, how whether you like it or don't like it is controversial. This is not controversial. This is something that, again, can, whether you're living in an urban area or a rural area, there's a plus at the end of the day. So it will be, the ultimate challenge will be to find champions, because every member of Congress or senator, we all have priorities, but if we have to somehow find a way to coalesce members and senators at the end to say this is really a priority, because a lot of them will say, yes, I want to help on this, but we've got to find champions who say, yes, I want to champion this.
Mm-hmm.
Going back in history a bit, some 3.5 decades ago, Congressman Mike Seinar and I founded the Rural Health Care Coalition in Congress. And we had over 100 members of that coalition on a bipartisan basis, and certain accomplishments were made. Now, when I look back, I see that a lot has changed in the delivery of health care in rural areas over the past 3 decades, most of it for the better. But the lessons that I've learned, I guess, in this process are two. Well, there are many, but two that I'll cite here. One is that in order for us to be successful, we have to bring along the people at the grassroots level. And when you deal with health care in rural communities, the people who are most interested are those engaged in the health care system in those rural communities. And not surprisingly, their first instinct is to defend the status quo. They want to ensure that their current hospital exists, that the current players stay in place. And so there is a great desire, as is often the case in public policy, for those who are most interested to want to keep what they have. It's very hard for them to see change, to make change. So you do need those leaders that Henry talked about in the Congress, but you also need leaders at the local level who can have a vision about what the change can be in the delivery system that will result in better outcomes for the people who live in rural areas. The second observation I'd make is that the big health care issue has been a very partisan issue for a long time. It didn't just begin with Obamacare. When I served on the Pepper Commission on Comprehensive Health Care, chaired by Senator Rockefeller, the divisions were stark on the big issue of what do we guarantee in health care, how do you pay for it, and so on. We see that today. So my hope, frankly, is that the rural health care issue does not become part of the presidential debate, because I think that will be divisive. I'd prefer that Congress approach this issue in a series of discrete measures that are focused on dealing with some of the rural health care issues. And if you watch Congress, it is able to come together in a bipartisan way on relatively narrowly defined, non-high-profile issues. As soon as the issue becomes high-profile, it seems as if the partisanship steps in. So I hope that we can be separated from the big debate over health care, and we can instead focus on a series of things that will make a difference, on ranging from telehealth to how you payments, how you attract the right personnel into the system, and so on. So the big needs are, one, visionary leadership at the local level as well as in Congress, and a little courage on the part of Congress to force sometimes a vision that may not be embraced locally immediately. And secondly, stay away from the high-profile issue and try to do this in a series of discrete measures.
So we have the administration, which is making this a priority. How do we get Congress to pay attention? And will the members of Congress pay attention to polling results like this that show that their voters, especially in rural areas, are interested in this as a voting issue? How big of a difference does that make, and what does it take for us to get Congress engaged?
Polling numbers always, when you're a member of Congress or Senate or elected official anywhere, you listen to numbers like that, where you might be able to latch on to something again that's not controversial. Tom made a good point too, that it needs to be kept under the radar somewhat, because if this does get into to that level, someone's going to throw a tomato in one of the presidential debates, and suddenly it's going to be, no, we're not going to do that now. So we need to figure out a way to empower. A lot of times people don't understand how important it is to show up with your member of Congress and senator back home. As obvious as that might seem to us in this city now, sometimes they don't think it matters. We need to figure out a way to get people from hospitals, healthcare facilities, and anyone involved to make those appointments, go to the town meetings, make the contacts. It does matter at the end of the day. When you visit a facility, for example, if they have a marquee, as trite as this might sound, when they have a banner that welcomes the elected official and they put it on their website and their photographs in the town newspaper, suddenly that official says, my God, that's really a cool issue, and man, they pay attention to me, and I might make it a higher priority now. So grassroots, as Tom said, will be critical.
Okay, any of our other panelists want to weigh in on this?
I would totally agree with what was said. Grassroots is so important. Look at America, all 50 states. Every state has a rural population in it. Red states have this, blue states have this. So this cuts across all divides. And it's something where every member of Congress, every citizen should be able to rally around. Even if someone from New York City, they don't see the benefit for helping South Dakota or Iowa, but there's rural New York, there's rural Vermont, there's rural, all these urban centers have rural components in their own state. So I think this is a rally cry. I really think this could take off like wildfire, because every state is affected by these closures. Yeah,
and our poll showed that it wasn't just the folks in rural America who thought this issue was very important. It was national. Congressman, I don't think
you have to convince members of Congress to be interested in the issue. You have 100 senators, and they all represent rural areas, as you say, every state. So the Senate is very open to this kind of thing. And as you noted, even urban representatives in Congress and the House will tend to be supportive of this kind of initiative. The key is, one, you have to, they want to do something on the issue, but they don't know what to do. So the key is to figure out what it is that should be done and to spell that out. And if you do that, and I hope this task force can, that I think will result in a lot of people embracing it. The second thing is, when I go back to what I said earlier, you have to help educate the local folks, because the resistance comes from those who want to preserve the status quo. So you have to show them that there's a better option.
Okay, great. So let's see if we can get a better understanding of what this population looks like. The demographics, rural Americans tend to be older, sicker. Help us to understand the healthcare challenges and needs of this population and what it could look like going into the future. What essentially is keeping you all up at night? And I'd love to start with Walter and Dr. McKay on this.
Well, what I'm most concerned about with rural America, and once again, you pointed out the aging process of rural America. Young folks are leaving rural America. Farms are being managed by the older generation. And with that, these folks aren't having access to care. They're not having access to specialty care. And that's a huge concern. And as you even look as communities age, you look at the toll on the EMS systems. That's another component of it. The hospitals closing all over the place and reducing services. I have read studies, multiple studies, where if $1 spent in the local community, it will return anywhere between 6 and 8 times over. So the goal of these hospitals should be keeping patients there. Not every patient needs to go to a tertiary facility. That will help keep these doors open of these hospitals. And we can talk later on solutions, but that's what's keeping me up. That's what's making me absolutely concerned for rural America is the lack of access to not only primary care, but specialty care, cancer care, and appropriate cardiac care and cardiac rehabilitation as well.
Yeah. So, Dr. McKay, you're on the ground, you're an internist, your system is doing a lot of innovative stuff, and we're going to get to that. But what are you seeing as the greatest challenges?
The greatest challenge really is how to get science to the bedside of the patient wherever they are. I think any of us go to an emergency room in this community, we'd all get an aspirin if we had a heart attack. And uniquely, Avera is positioned to do those things. But I was working at our eCare hub last week, and I had to send a patient outside my organization to go get appropriate stroke care. As we've gotten better at chronic disease management, we've gotten more subtle at what the specifics are to chronic disease management. And I think stroke's a really good example of this. So we become more stressed and more strained about how do we get our patient to the right spot. And unfortunately, what our organization has experienced is we've sort of maxed out the critical access hospital support system, and now we're putting pressure on our tertiary care center, who is kind of pressed for beds. So there's a double-edged sword to this. The other thing I'd add in is that a lot of these rural issues are just magnified from what you might see in a more urban area. So there may be some solutions on the ground in a rural community that could also be effective in other areas, making it much more approachable to other members that might have some concerns.
Great. And we want to get to some of those innovative solutions. And I know, David, you're working with a company that also is involved in the innovative solutions. But before we do that, let's talk about we've heard a lot about access issues. What are the biggest access issues? You know, our poll confirmed a number of major problems in access. The first is in access to physicians and other clinicians. There was a particular emphasis on medical specialists, such as cardiologists, gynecologists. More than half of respondents said that easy access to medical specialists was a problem in their community. And what about behavioral health providers? We know that we have a challenge there in access. We have that not just in rural areas, but in all areas. Our poll showed that a majority of rural Americans identified this as a problem. So how significant a problem is access to physicians and other clinicians in rural areas? And are there specialty areas that are particularly difficult? And does one rural area look like the next rural area?
Out of the 7 states that we work into, I can definitely say there isn't one solution. There isn't one answer. Every rural community is different. Some rural communities have access to certain specialty cares where other rural communities don't. So there isn't a one size fits all or one answer fits all, because you have to look at it community by community and do a community assessment. I'd say broad strokes, mental health, access to mental health is huge, a huge problem. Access, again, also to some of your specialty care. There are times where even with telemedicine, even with doctors coming into the community from more urban areas for office visits on specialty care, the waiting time can be months on some of these.
Months.
Months. And that's a problem. That's a problem. When you have a chronic disease and you need to see a physician, and it can take you months to get in to see a physician if you're unable to travel hundreds of miles to the urban center, that can be a real problem.
Can I just add on something you said about the mental health crisis that we have? And in rural areas, there's also a particular challenge. These are small communities, right? So if you were to see a psychologist in this area, the likelihood that you would see your neighbor's car in the parking lot, right, or bump into somebody in the waiting room is unbelievably remote. But there's this stigma associated with mental health, and it's often confused with mental illness. And so not only can telehealth provide better access, it can provide a level of privacy which will drive better compliance.
Absolutely. I've seen examples where they've had telehealth consults in physician's office for mental health, where you could be sitting in the waiting room with your neighbor. They don't know that you're there for a well visit, a checkup, or a mental health consult. Or an appointment like that. So it helps remove that stigma that's perfect example.
Congressman Talkie?
I was going to say, in Iowa, I think, I don't know about all the rest of the country, but it certainly seems as if there is a huge problem with facilities for treatment of addiction. And the addiction problems are becoming more acute. That was referenced in the film, which was excellent, by the way. The opioid problem is significant, but it's also alcohol and all the other things that we've seen before. And it's hard even to find detox, but of course, once you get beyond detox and you're trying to get the longer-term care, you don't have the group homes in the rural areas. You don't have the access to many of these services that allow people to overcome addiction, and that, of course, leads to a lot of other health care issues. And so I think that's an area where access is particularly problematic, and the need is growing.
And in some areas, there are language barriers that have to be dealt with as well, and that's increasing by the day as we've seen the numbers of immigrants coming across the border. I had an area that had 700 miles of the Texas-Mexico border, and even if you're not right on the border now, a lot of these immigrants are being transported to other parts that wind up in rural areas. So sometimes the new factors that involve what language barriers are yet another issue.
So we definitely want to get to the issue of the critical access hospitals, but telehealth keeps coming up. So let's go ahead and address telehealth and technology. And in particular, David and Dr. McKay, you two are really moving forward on some of these technology solutions. And I'd love to hear from both of you about where you think the future is here and what's already happening. So,
Dr., to kick us off?
Well, I think, first of all, I can't say enough about the benefits that I received from the work the Helmsley Trust has done. I'm a product of what telemedicine means in this day and age, and I'm a physician who can now champion patient care in a way that I always dreamed I could.
Yeah. And could you actually, before you go any further, could you just tell the folks what Avera Health is,
Sure.
where you are,
Yep.
and then get back to what you're doing?
Sure. So we're actually a healthcare system. We're in Sioux Falls, South Dakota, but we cover eastern South Dakota, southwestern Minnesota, northwestern Iowa, and northeastern Nebraska. And we have 30 critical access hospitals, 5 PPS facilities, 200 clinics, multiple long-term care facilities, and other affiliations across that region. At the heart of what we do, and our second largest region, is actually our eCare telemedicine hub. That hub was started 15 years ago, or about 10 years ago, and it houses multiple eCare delivery systems. The first of which is eMergency Room, that actually supports some of the local emergency rooms in Texas. E-long-term care, e-pharmacy, and now I work in the e-hospitalist arena. So we've tried to capitalize on this, this integration of care delivery across our states using technology. The Helmsley Trust has supported us because we've been able to maneuver and deliver care without having to worry so much about the payment reform required. Because of the work the Helmsley Trust has done, we've now got some really good things going on, like the Interstate Medical Licensing Compact, making it somewhat easier to get licensed in other states. But I think where we see limitations is in the payment of how healthcare gets reimbursed. So most of what we have done has all been based in subscription-type services to our facilities. But as Walter's pointed out a number of times, it's been really, really good for the patients. It's probably not been financially as beneficial to us. But what it has been beneficial to is the system as a whole supporting healthcare. So what I do in telemedicine really is about that, what I talked about earlier, getting science to the bedside in a unique and a different way. I use it for multiple things. I use it to transfer patients. I use it to work with other specialists. Sometimes the emergency room doctor and the hospitalist are standing side by side viewing a patient. And I also admit patients locally. I admitted somebody from Iowa just last week, and I did it over the camera. The really interesting thing about it is that our billing system has created a foundation for the evidence of medical care delivery based on a physical exam. No one in healthcare would ever tell you a physical exam is not important. It's truly important. However, that was really all they had when the billing and the coding systems were written many years ago. So the requirements for today of what we show we did are very limited by, we are limited in our ability to use technology in those circumstances. But what's really interesting is when I did this telemedicine and you took away my ability to lay my hands on the patient, I had to do something that lots of people complain about with their doctors, and I had to talk to the patient. And I felt like a doctor. So at the end of the day, what has been really wonderful about the work that we do at Avera is that we've really created this construct to support rural healthcare. We need payment reform, licensing reform, technology improvements, but at the heart of it all is let's let doctors use technology as a tool and give them a means to deliver care without respect to worrying about all of the regulation around the fact that when I lay my hands on you, that means I can put a bill in and a charge.
All right, David, so tell us about your company and what it is that you all are doing and where you see the future of technology in rural.
Sure, I think the leveraging technology is a great way to improve access. I think a lot of the points that have been made. But one of the initiatives that we've been working on is putting telemedicine in elementary schools in rural and low-income areas. And it's really simple if you think about it. You know, let's say, little Johnny is sick and goes to see the school nurse. Right there's a device, if you haven't seen it, looks like a kind of a mini ATM machine. And the school nurse can, let's say Johnny's got red eyes. They can dial up a physician right there. And then the physician can say, you know what, it looks like allergies, Johnny's gonna be fine, he can just relax and rest there till he feels better. Or, wow, it looks like pink eye, that's highly contagious. Let's dial in the mom right now, we can call in a prescription to the Walgreens. And that's huge, because a couple things happen there. One, the return to classroom rate jumps from 75% to 98% when you have telemedicine. And a lot of these moms and dads don't have paid time off, right? They can't just leave their job to go pick up their son or daughter. And they don't have access to a primary care doc. So then a lot of times they're going to the emergency room, which is much more expensive. So by leveraging that kind of technology, which is pennies on the dollar compared to putting a physician in an elementary school, we can drive better outcomes.
Walter, how far can we go with technology?
We can go incredibly far. We have demonstrated so much. We have an Avera has an e-school nurse program that's very similar, because in a lot of rural South Dakota, especially when there's multiple schools, it's hard to find a nurse to even work in one school, let alone if there's 3 schools that the nurse has to cover, giving out medicine, seeing that. So they have done similar things with that. You can e-mental health care. We have done consults and funded consults programs for mental health. Emergency, like Dr. McKay has alluded to, but it's really endless. I don't want to sound cliche and just slap an e-sticker on it, but there is so much what can be done and supported with today's technology, where you could have a virtual physician or support the PA, the nurse practitioner, or the other physician that may be on the other side. And that's just having the e-products available to these physicians out and PAs in these very small communities increases the likelihood that PA, that physician, will stay in that small community, because he or she has support now. Where before, they didn't have support, and so they would burn out real quick. They'd be on call all the time. You can't have a life. And I have heard countless times from physicians and also hospitals, not just Avera, but other hospitals that have subscribed to eMergency and some of the other e-care products. This has been a recruitment tool. This has kept older physicians working in the area and helped support younger physicians and encouraged younger physicians, because they have resources.
So in e-health is such a broad subject, but to kind of elaborate on that, remote monitoring devices can play a crucial role in rural areas. So whether it's blood cuff monitors that are hooked up via Bluetooth, or whether it's cellular enabled blood glucose monitors or scales. And so doctors can monitor chronic conditions, whether it's diabetes, congestive heart failure, high-risk pregnancies, remotely. And then so in these rural areas, let's say someone has a 45-minute drive, if they don't need to see the doctor, they don't need to go. But more importantly, if they do need to go, if the doctor or the practitioner sees something, they can make sure that they see their patient.
So let's talk a little bit about the challenges to tools that involve technology. Dr. McKay, you mentioned the word payment more than once. And also, we know that there are some challenges regarding broadband access.
I would also add in privacy compliance is becoming more and more and more of a barrier. As you know, HIPAA was in place back in the 90s. We've adhered to that for many, many years, and what's happening is that the rules and regulations around what HIPAA compliance means in an electronic world comes fast and furious, so our EHR vendors are constantly playing catch up. So I would add that into the mix of payment reform and connectivity.
A lot of people don't realize if you look at the map, a map of the United States, how many areas there are that don't have broadband. So you can't even deliver telemedicine to these areas. And I happen to be working with another corporation that's very interested in expanding that too. So, and they are committed. So it's hard to connect the dots though sometimes with the right agencies who will allow for the spectrum for this to happen. But that's being worked on as well separately. So hopefully that can dovetail with this project.
I spent a good deal of time in the telecommunications industry, and especially when I was chair of the United States Telecom Association and worked with all the rural companies, I saw firsthand a lot of the challenges of deploying broadband. Actually, the small companies do a relatively great job at this. It's the large companies that serve rural areas that have the bigger challenge because when it comes to allocating capital, economically it may not make sense to do it in rural areas, and many of the large companies don't qualify for some of the federal programs that would support deployment in rural areas. So this is another can of worms, which we won't open completely here, but it is a very important part of telemedicine. One other piece is that it's a little bit of chicken and egg. If you don't have the services to offer, then the deployment of broadband makes less sense. If you have the services to offer, it makes more sense. So which comes first, the availability of the services or the broadband deployment? So I think that there is work that can be done here. It's going to happen, but it's a matter of time and financing.
Financing. Again, we're back to the money questions, but let's get back to reimbursement for providers that offer these or other services that we might need. We are moving across the country. We're trying to move toward more value-based systems, payment systems, alternative payment models to get us to value-based healthcare. And how hard is it to create a system that is an accountable care organization or bundled payments, or to adopt some of these structures that we see in the rest of the country in rural areas? And is that necessary to be able to get payment for services that make sense? And Dr. McKay, you might take issue with my saying that it might be harder in rural areas because you all are doing it.
We actually have the largest rural health ACOs out of ERA. We've got several of them. The key to the success truly was removing the payment barriers and allowing providers to use their unique creative skills to take care of patients in their community. And those two things together have resulted in some major cost savings, patients staying in their community more frequently, fewer use of resources that we didn't have access to before for our patients who might be homebound. And then, of course, for us internally, referring out to other healthcare organizations where the care might be more expensive is something that we now are able to pay attention to. The one thing that it's really changed, though, is it's this idea of physicians using data in the same way we use our stethoscopes. So the data about your patient population is as much like listening to your heart or a patient's heart as anything else. And that is the new skill set that goes along with this payment reform and how we're going to keep rural health in a good place.
So I'll ask the rest of the panelists, is what Avera doing an exception that they're going this route? Is it hard? Are we seeing some of this? What's the landscape?
I can say what Avera is doing is very unique. We funded much of the programs to bring Avera to this. There is really no one else in the country doing it to the scale that Avera is doing it. I can even say no one else in the world is doing it to the scale as Avera is doing it on as many platforms. Just broadly, you know, the amount of money Avera is saving the taxpayers and private insurance companies is staggering through unnecessary for not transferring patients, for keeping patients at home. It's better on the patients, they get to stay home. It's better on the family that don't have to travel the hundreds of miles to support grandma, grandpa, mom, or dad who may be sick. But if they can receive the quality care in their local community, it's saving hundreds and hundreds of millions of dollars. But to the point is, telemedicine's being done with here and there, dips and dabbles all over the United States. And it's providing a cost savings, but nothing to the scale of where Avera's demonstrated this. And that's something that's scalable all across the United States. We demonstrated this in seven states with a frontier population in a majority of the states. And if it can be done here, there's no reason it can't be done in California. There's no reason it can be done in Texas, Maine, fill in the blank. And that's my hope, is that it's continue to spread.
Yeah. Okay, so I just want to let folks in the audience know that we're going to spend about maybe 10 more minutes talking. We're going to talk about critical access hospitals and the closures and what needs to happen there. And then we're going to open it up to you all for questions. So get your questions ready, and we'll get to your questions in about 10 minutes. So we heard over and over again from all the speakers that we have these critical access hospitals closing. What is the problem? Why is this happening?
Well, it's happening because of the economics. If you have a 50-bed hospital and you have 10 patients on a daily census, you probably aren't going to make it. And it's happening because the medical personnel may not be in the community to support the hospital. It's happening because, let's say, going back to my state of Iowa, people want to go to Rochester or Iowa City. They don't want to the Mayo Clinic in Rochester or the University of Hospitals in Iowa City if they have some significant need. They don't necessarily trust what's happening in their local communities. So I know there's always angst when a hospital closes, but I think that we have to, I think that's one of the challenges, is if we spend our time trying to preserve every existing hospital, we're fighting a losing battle in my view. You have to figure out how to turn those facilities into something that works in those rural communities. And it's driven by economics. And so I'd say, yes, we need critical access hospitals. We may not need all of them that we have in rural areas, and there may be better alternatives for providing better services at a lower cost.
Just to add on that, I think there's a variety of reasons why critical access hospitals are closing. Some of it's poor management. Some of it they're owned by tertiary facilities, and it's a business decision on that. And depending on who the mothership might be, who owns a critical access hospital, could be a different business model. They could believe in just moving patients, using that as a filler to their tertiary facility. There's also problems. Every state's different. You can't say it's a one-size-fits-all that people don't want to go there, because some people do want to go there, but if you're up by Mayo, people would rather go to Mayo. I get that, you know, but you also have to look at it too, that some of these hospitals might need to close. I'm going to be blunt on that. You look in Nebraska, they have by state regulations that every county just about should have a critical access hospital or have a hospital in it. And counties are very teeny in Nebraska. So do some of those need to close? Well, possibly, because they can only slice the pie up so small to make it salvageable and fundable. So, but that's something where you have to look at it state by state, almost county by county, and organization by organization, what's going on with these critical access hospitals.
So what can they look like in a transformed system?
Well, I think what we talked about earlier today is the critical areas around emergency room, primary care docs. Like that's what these communities are missing. So how can we repurpose these facilities to focus on those areas? And then, of course, you know, we touched on this as well, this lack of specialty providers that we have in these rural areas, which is a huge issue.
Mm-hmm. Okay, so in the few minutes that we have left, I would simply like to ask each of you to tell me if you could just wave your magic wand and address one issue that you think is most important, what would it be? You can go further and say what you would do, but what is most important to you? And Congressman, can we start with you at the end?
Well, I think the thing that could have the most impact most immediately is to change payment systems for the delivery of care services, particularly via new technologies, and to change the reimbursements for recognizing the unique nature of rural areas.
Walter?
Based on what I hear from the communities and based on from just observations, I would totally echo what the congressman stated.
This is going to maybe sound cheesy, but I want to feel like a doctor. And you'll make me feel like a doctor if you can deregulate all of what it means to document a visit, what it means to have a visit, and more importantly, what it means to report and get reimbursed for the care that we deliver.
It's hard to say just one because all of these are important.
We'll give you two.
You know, expanding federally qualified health centers, reimbursements, telemedicine, and making more incentives for medical students to be attracted to these areas. I mean, it all goes together, so I don't know that I could say just one.
We'll call that one package. Okay, David?
I go to mental health because it drives so many other chronic conditions, whether it's obesity, diabetes, heart disease. And so I would focus on mental health. Clearly, there's a lack of specialists in that area. So I think leveraging telemedicine, something that you mentioned earlier about the language barrier. If you just think about how unique telemedicine is, you can dial up any language that you need. So regardless of where you are, you can find a professional that speaks that language. I would focus on the mental health aspect.
Okay. All right, we're going to open it up to your questions now, and we have one over here. And if you could please identify yourself.
I'm Dr. Caroline Poplin. I'm a primary care physician, also an attorney, and I wanted to suggest something in answer to Dr. McKay. Coding is based on 1950s medicine, a single acute care problem. I've written about the differences. That's not a congressional law. That's an administrative action, and it can be changed administratively to reflect chronic diseases, physical exam unchanged. That's doable. And I wondered if some of you are legislators, if you've considered it. AZAR could do that with
Any
notice and comment
responses?
rulemaking.
Amen.
Okay, I think the panelists heard. Did you have a question?
Yes.
Okay.
Thank you. I'm with the National Council of State Boards of Nursing, and there's been a lot of talk about physicians and primary care, and the report documents nurse practitioners and physician's assistants. So what role can they have in increasing access to care in rural America, especially when it comes to things like the opioid epidemic and medicated assisted treatment?
So that's an excellent question, and on the task force, we're going to be addressing workforce issues, and as part of that, that raises questions about scope of practice and how we get clinicians practicing to the full extent of their license. So,
that's where telehealth again comes in. What we do is we support those nurse practitioners and PAs locally to keep people in their facility, and it grows confidence, it grows knowledge. And then I think the key piece to this is that the people in those communities know those patients so well that that's a part of the medicine of keeping rural health in a good place. So telemedicine to support with experts available to people whenever they need it really is the answer.
Anybody else? Okay, there's a question in the back there. I see a very excited hand.
My name is John, and I'm from Anthem. And it was mentioned earlier about that there are rural hospitals that have to close due to the population and due to supply and demand. So I wanted to ask what would cause those hospitals to open in the first place?
If you're talking originally opening it in the first place?
Yeah.
Okay, well,
How did we get here?
Look at how it was. A lot of these hospitals are 50, 60, sometimes 70 years old out in these places. And when rural populations were much higher 50 years ago, 40 years ago, there's been a continued trend of people migrating from the rural to the urban. So you look at the statistics way back when, there were babies being born in those hospitals, many more families. You look at the communities over there, you saw communities of 5,000, 10,000 people in the rural areas. Now, some of those same communities where they might still have a hospital down to 300 to 500 people.
You mentioned earlier that some of them were legislatively required to be there, which is never a good idea.
Yeah.
Okay. Yes, right here.
Thank you. I'm Barbara Gay. I'm from Leading Age. We represent not-for-profit nursing homes and home care providers. We would just urge the panel to take long-term services and supports into consideration as part of the issues that you look at, because rural nursing homes are also closing. We also have tremendous workforce challenges. It's very difficult and expensive to provide home services in rural and frontier areas, so just hoping that that will also be an issue for you.
Any response from the panel?
Excellent point.
We see that in our organization as well. It's something we're very much struggling with. It's where we've been able to leverage telemedicine to support it. But back to the regulation piece, the amount of information these facilities and home care facilities have to collect to just say, hey, I did this visit is astronomical, and quite frankly takes more of their time than actually taking care of people does. So some deregulation around the minimum data set and around the home care reporting tools.
Okay, we have a question here in the front.
Yes, Ray Bridgewater, President and CEO of the Assembly of Petworth. Where do you see the uses of telemedicine medical mobile units going out into the rural area, taking the hospital to the community?
Walter, I think you have some cool stuff to say
We got
here.
some cool stuff that's going on in South Dakota. It's funny, I swear you were prompted for that question. We have taken it to a whole new level right now with the care of emergency mental health crises. So coming up in year 2 of this grant, we are putting these devices in police officers' hands. Those are the ones who have the first contact with people who are having a mental health crisis, and that way they can be assessed. They don't have to go to the local jails. They get assessed. They get assessed by a physician team, and the patient's getting treatment right then and there. And that's just the tip of the iceberg. There's so many places. I have, in the back of my mind, there's so much spinning over there. You can help that out with paramedics to have physician control, better medical control. We haven't done that yet, but that's The one example that we are currently doing is the mental health aspect, where it's going into the LEO's hands.
But how widespread is stuff like this?
Well, this is the first, we're the first that I know we're doing it. It's a pilot program right now. This is small, just happened in the state of South Dakota. And there's selected agencies that are participating on this as a trial. And hopefully, if everything works, this thing's going to expand to multi-states. So, and I'm sure there's other places where they're doing, I know there's other places where they're experimenting with telemedicine in the hands with EMS responders and flight nurses, whether it's with Google Glass, eye camera type things and whatnot, and other locations in the United States that we're not currently funding right now.
Okay. Yes, right here, and then here.
Hi, I'm Ariel Kane with Progressive Policy Institute. I totally agree with all you're saying about right-sizing rural health and making sure that we don't have a million critical access hospitals that are all getting subsidized. However, I didn't hear a lot about maternal health, and I just don't know, if you can't have a baby in a rural area, we're never going to have vibrant rural communities. But also, it doesn't, I don't know, I just think that's like a piece I don't quite understand how it fits into these ideas.
I can speak a little bit to that. I actually happen to have an identical twin sister who's an obstetrician, and she's across the street at CMS today having this very conversation with them. What we are experiencing in rural communities is that our women are having to drive farther and farther and farther to receive their maternity care. And the FQHCs definitely feel a gap. However, what is being told is patients are saying when they're pregnant, okay, go find a doctor. Well, that's a whole other adventure that's not been very successful. So to your point, the conversations that we're having are really around things like, how do you do OB crisis management in a critical access hospital? How do you appropriately risk a patient to be supported in a critical access hospital? And the work that's been done at Avera has been around looking at resource allocation for things like blood, because you have to have a certain amount of blood products available. We're asking this question very deeply. The biggest issue with maternity care, though, is that it was the first and most continuous bundled payment that we have. The reimbursement hasn't changed a whole lot, and in rural communities, not one health system has any kind of want to put money into this because they're going to lose money on it. And I would say that that's probably not just true for rural care, it's probably true across the board. But when you think about women as the drivers of healthcare in a family, and you look at the health systems that they're affiliated with who are running a very low bottom line anyway, it's very hard to want to make that investment. I think some of the discussions around maternity care in rural facilities might actually have to be to roll back the bundle. Because what would happen in that way is you'll end up with fewer NICU admissions. So you have to look at mom, you have to look at baby, and then you have to look at where you want to put the payment so we don't have babies going into NICUs.
There's a local company here that's called Baby Scripts that's doing a lot with technology in that area to work with physicians, with moms, with pregnant moms in rural areas to monitor. And they've got a lot of cool applications on the phone. They've got the remote monitoring devices. So that it doesn't replace the hospital, but it's a way to keep the mom better engaged with the doctor.
Okay, right here.
Hi, Pam Schweitzer. I'm the former chief pharmacy officer for the United States Public Health Service, and I'm from South Dakota. So, yeah. So my question was really on the broadband. You had mentioned that there's all efforts underway, and to have that infrastructure in place is so important. Is there any way we have an idea of the priorities or how that's going to be implemented? Because that would really be nice to tie into with all the other infrastructure that needs to be put in place. That's the first question. And the second question, because I'm a pharmacist, I'm also very aware and been tracking all the independent, the owners, the independent pharmacies in these rural communities, and they're just shutting down across the board. And I just wanted to make sure that got mentioned. I didn't hear it get mentioned. That needs to be something that needs to be addressed too, because these are small businesses going out of town, and it could be the last medical business in a town.
Well, the reference I made earlier to the lack of broadband in different parts of the country, I happen to know a little more about it because the company that I'm working with the president of Microsoft on that, and they've made a big public, not just a public issue, but they're in the weeds deeply about trying to take advantage of, I believe the term is white TV spaces that are available to use for broadband, which then of course could enhance telemedicine. But there are restrictions. A lot of it's very technical. Tom probably knows a lot more about the technical barriers that exist now for them to be able to access a lot of this spectrum to provide that. But it's ongoing. And again, I think when people see the map of lack of broadband in this country, you'd be shocked that these areas are simply blacked out. But I know that that's going on now, and I mentioned earlier maybe it can dovetail with what we're doing here.
I just offered the observation that I do think the solution is going to be 5G. And while I generally am not supportive of a lot of regulation of the industry, my view is that when spectrum is granted for deployment of some of the new technology like 5G, that it would be appropriate to have it tied to deployment on a broad basis, so that you don't have, so that you reduce the areas of the country that don't have access to broadband technology.
I was going to say, as it relates to the second part of your question, I mean, the pharmacist is probably the most underutilized healthcare profession that we have out there, right? We have these highly trained pharmacists, and in these rural areas, a lot of the residents are going to the pharmacist and asking a myriad of questions, right? It's like kind of their healthcare professional. And it goes back to reimbursement, right? So if we're reimbursing based on volume, right, how many pills did you sell versus reimbursing on value, right? So if we can start to compensate those pharmacists for the interaction that they're having, so they're driving compliance and better outcomes, we can preserve those businesses, because that's a really important part of the rural community that we can't lose. Sure.
Okay. Yes, right here.
Hi, Laura Dillon with the American Academy of PAs. First of all, I want to echo your comment earlier and thank you for focusing on the workforce issue. I have a comment and a question. So just to say that, I'm glad you're focusing on the workforce issue, as we see a shortage of physicians, and the PA community is supposed to grow around 40% in the next decade. So we really see ourselves as a solution to some of this problem. And particularly there's issues in the Medicare program that we're seeing, such as the inability to be directly paid. So I just wanted to flag that for you guys. And my question is, how do we get more involved with the workforce? Are you guys having stakeholder meetings? How can we, make sure that these other provider communities are being plugged into the process?
I'll take the last part of that question first, and that's we would love to have, folks. We're just beginning. We have our first task force meeting toward the end of July, and we're going to be having lots of conversations with folks. So I strongly suggest that anybody who would like to speak with us about this, contact me, Marilyn Serafini. I'm on the BPC website called BPC Ask for Me, and we'd love to talk to you. In fact, you took my closing. So, anybody else want to comment on the workforce issues? Okay. All right. Yes, I see a question way in the back.
Hi, I'm Holland Smith, and I am here as a part of the American Association for Marriage and Family Therapy, and I'm actually here as a grassroots advocate, speaking about getting us covered and reimbursed by Medicare. So this brings my question of, is there a possibility to have a focus on creating more equality for mental health professionals who are all trained at the same level and have the same abilities as a mental health professional to get the same reimbursements and the same coverage for all health insurance companies, but also Medicare in rural communities, which I think would then grow the workforce, if that makes sense.
Anyone?
Well, it sounds to me like we have a lot of opportunity with respect to the old parts of Medicare that maybe don't fit into the paradigm of care delivery today. What we know is that What did you say, 58 years ago when we established billing codes, it was one patient, one doctor. Now it's one patient, many team members. The physician might be the leader of the team, might be leading other people. And so I think as we talk about what team-based care is and what reimbursement models are, I think the conversation really is looking back to the roots of how this whole system was created and maybe just stepping back from that and saying what makes sense today.
Mm-hmm. Yes, question here? Oh, okay.
This is Dr. Poplin again. As long as we're talking workforce issues, we might, will you be considering training some people in the local community, of the local community? That's something that's been done in Mississippi. It's frequently done in developing countries. And that is a way of keeping people in the community and giving them a resource when they need it.
Okay, thank you for that, Dr. Poplin. Anybody else? Okay, yes, right here.
Spencer Jones with the National Association for Rural Health Clinics. We've seen over 300 rural health clinic closures since 2012, and I was wondering what you all would do to help stem the tide.
I think there's a lot that can be help stem the tide of closures. Once again, you got to look and see why are they closing. Is it due to lack of population? Is it due to lack of providers? We've seen some rural clinics that actually flourish because they do have the providers and the population base. But it's something where you really have to look into it and see the true reasoning why it, because even still, it's hard to get people to want to commit to work in rural America, and in some of these very remote rural areas. So that's where you almost have to leverage technology somehow. It goes, I hate to beat a dead horse, but you have to think outside the box and leverage different ideas to, I don't want to say to replace people, but to supplement the workforce that you already have there, because you can't, with the shrinking rural population, you can't have the doctors, you can't have as many nurses, just because it's shrinking. It's the nature of rural America.
And I was going to add, hand in glove with that is the reimbursement rates associated with leveraging the technology to make sure that the rural health clinics are incentivized to embrace that technology and they're reimbursed appropriately.
So with that, we're going to bring this session to a close, but I want to just make sure everybody understands this is the beginning for us. It's the beginning for our task force. We heard a lot of important information and questions and comments today. We heard a lot about the various access issues. I didn't count the number of times we heard the words reimbursement and financing, but we heard them a lot. And so we're going to be looking at those. We heard about opportunities, cool, innovative things that are already starting to happen. We're going to be looking at those. We heard that CMMI is going to be testing new approaches. We're excited about that. And we heard about our polling results, which absolutely show that things we already knew about access and problems, and things that were very definitive about how important this is to voters, to people and to voters in 2020. So again, we encourage you to come along with us on this journey, and we'll be starting in earnest as of now. So please join me in thanking our panel for being here and all of our speakers.